Type 1 diabetes is a chronic autoimmune disease, and the major feature of this disorder is increased blood glucose level. We call this state hyperglycemia. Hyperglycemia develops due to the insulin deficiency, and in turn, insulin deficiency is caused by the loss of pancreatic beta cells which produce insulin. Type 1 diabetes is one of the most common disorders in the childhood. In most cases, the destruction of beta cells is caused by autoimmune reaction with formation of autoantibodies. Such diabetes we call immune-mediated diabetes, and it's the most common subtype of type 1 diabetes. In small subset of patients, destruction of beta cells occurs without autoimmune aggression, and because we do not know the reason why beta cells destruction occurs, we call this subtype idiopathic type 1 diabetes. But idiopathic diabetes is quite rare, so in this case we will concentrate on the most common subtype of type 1 diabetes, which is immune-mediated diabetes. As we see, according to the current classification of diabetes by American Diabetes Association, we have 4 major forms of diabetes. It's type 1 diabetes, type 2 diabetes, some specific types of diabetes as MODY for example, and gestational diabetes. So in this case, we will discuss type 1 diabetes mellitus, which is caused by autoimmune destruction of beta cells. The most common subtypes of diabetes is type 1 and type 2. The problem is that sometimes it's quite hard to determine which subtype of diabetes is it. In most cases, type 2 diabetes affects adults, and type 1 diabetes affects children. But nowadays, we know that exceptions are possible. The key feature of type 1 diabetes in children are polyuria, polydipsia, and the presence of diabetic ketoacidosis. Also, we have to know that type 1 diabetes usually affects people younger than 35 that have low body mass index with a history of unintentional weight loss, ketoacidosis, and blood glucose level higher than 20 at presentation. And to explain all these features of diabetes type 1, we have to know the pathogenesis. Before pathogenesis, we have to highlight that type 1 diabetes is less common than type 2 diabetes. Among all people with the diagnosis of diabetes mellitus, only 10 to 15% have type 1 diabetes, and other approximately 85% have type 2 diabetes. But if we are speaking about child with high blood glucose level, then diabetes type 1 is our first suspicion, because as we see from the graph, the highest risk of diabetes type 1 have children around 10 to 14 years old, and after this there is progressive decline in incidence of type 1 diabetes. In the pathogenesis of type 1 diabetes, there are 2 cells that play a crucial role. It's T helper, which is CD4 positive T cell, and B lymphocytes, which produce antibodies. We know that type 1 diabetes is caused by autoimmune reaction. The triggering event of autoimmune reaction typically is caused by viral infection or some environmental exposure to toxins, for example. But the feature that determines whether autoimmune reaction will develop or not are HLA alleles. And to explain this, we have to know the pathogenesis. So there is pancreas. Pancreas has a lot of beta cells, and beta cells produce insulin. We have a lot of different tissues. Let's take muscle tissue for example. Tissues desperately require glucose for their metabolism, because glucose is fuel. In order to uptake glucose from the blood, they need GLUT transporter. GLUT transporter uptakes glucose from the blood and delivers glucose into the tissues. But GLUT transporter by itself is very slow. So in order to speed up this glucose transportation, tissues have insulin receptor. And when insulin in the blood binds to insulin receptor on tissues, With binding, insulin significantly accelerates the function of GLUT transporter. And now, under the insulin effect, GLUT transporter can deliver significantly higher amount of glucose molecules from the blood into the tissues. So let's suppose that GLUT transporter can uptake just 2 glucose molecules by itself, and for other 7 glucose molecules, GLUT transporter requires insulin. And by this insulin effect, we can maintain normal blood glucose level. And also, we can maintain sufficient income of glucose to the tissues. Also, we have to know that glucose level in the blood is also maintained by liver production of glucose molecules and by kidneys reabsorption of glucose molecules. So all these mechanisms help us to maintain normal blood glucose level. But beta cells are not immortal. They can die of old age in the process of tissue self-renewal, or some virus or toxins can provoke their death. With death, intracellular content of the beta cells released into the blood. Let's call intracellular content of the beta cells beta cell antigen. When beta cell antigens appear in the blood, antigen-presenting cells phagocyte beta cell antigen and present some parts of the beta cell antigens on MHC2 receptor to T helper. The logic is that antigen-presenting cell want to know, is beta cell antigen normal material or it's something pathogenic? T helpers scan beta cell antigen, and in normal condition, T helper recognize it as a normal substance, and thereby they do not trigger inflammation. But some people have MHC2 receptors that are produced based on HLA-DR3-DQ2 and DR4-DQ8 alleles, and in this case, most probably, inflammation will develop. And to explain why, we have to know how antigen presentation occurs. So let's suppose that this guy is beta cell antigen. In normal condition, when beta cell antigen released, macrophage intake beta cell antigen in order to present it to T helpers, and antigen presentation occurs by an MHC2 receptor. What we have to know about MHC2 receptor is that it's a protein, and the genetic information that tells us how to make MHC2 receptor is contained in the gene that is located on chromosome 6, and we call this gene HLA-DR gene. But we have different variations of HLA-DR genes, and such variations we call alleles. The simplest analogy is the eye color. You see, we all have genes that encodes the color of our eyes, but some of us have blue eyes and some of us have black eyes. And in this case, genes that encodes blue eyes we call blue allele, and genes that encodes black eyes black allele. So we all have gene that encodes eye color, but this gene can be different, and different variations which are blue and black colors of the same gene that in this case encodes eyes we call alleles. So in case of diabetes type 1, we all have gene that encodes MHC2 receptor. We call this gene HLA-DR gene, but this gene can be different, and different variations of HLA-DR gene we call HLA-DR alleles. For example, if person has HLA-DR1 allele, this person will have MHC2 receptor that was made based on genetic information in HLA-DR1 allele, and such MHC2 receptor presents beta cells antigen in a perfectly normal way. And when T helpers income to this receptor, they recognize beta cell antigen as a normal substance, and because of this, they do not see any danger. If person has HLA-DR2 allele, this person will have MHC2 receptor that was made based on genetic information in HLA-DR2 allele, and such MHC2 receptor presents beta cell antigen also in a perfectly normal way. Thereby, there will be no inflammatory response. But some people have HLA-DR3 allele. Thereby, in this case, person will have MHC2 receptor that was made based on genetic information in HLA-DR3 The problem is that this particular MHC2 receptor do not know how to present beta cell antigen to T helpers. The same is true for people with HLA-DR4 MHC2 receptor that was made based on genetic information in HLA-DR4 do not know how to present beta cell antigens to T helpers. And when T helpers income to MHC2 receptor, in this case, because beta cell antigens are presented in abnormal way, T helper cannot recognize it. And if T helper do not recognize normal substance, we have a problem. Because now T helpers thinks that this substance is abnormal. And abnormal means dangerous. In response to dangerous substances, T helpers becomes activated. And in this state, they activate B lymphocytes that begin to produce autoantibodies. And also they activate T killers with macrophages. So now we will have autoimmune reaction in a full scale. So in individuals that have HLA-DR3 and 4Rs, MHC2 receptor presents beta cell antigens in abnormal way, and because of this, T helpers recognize beta cell antigens as something dangerous. So in response to this, T helpers becomes activated. Once T helper becomes activated, T helper induce activation of B lymphocytes. If B lymphocytes becomes activated, they begin to produce antibodies. B lymphocytes begin to produce antibodies against beta cells components. First of all, they produce antibodies against protein tyrosine phosphatase. Also, they produce antibodies against glutamic acid decarboxylase. In addition to this, they can produce antibodies against islet cells and against zinc transporter. Antibodies are highly reactive substances that can cause severe direct injury to pancreatic beta cells. The peak incidence of insulin antibody development is at 1 to 2 years of age, and usually these antibodies have strong HLA-DR4 association. After these two antibodies, B lymphocytes begin to produce other antibodies, as antibodies against protein tyrosine phosphatase or antibodies against zinc transporter. And very important that the major risk factor is HLA association, because if MHC2 receptor works properly, T helper would not trigger autoimmune reaction. Also, T helpers activate T helper type 1 cells, and in turn, T helper type 1 cells activate macrophages. With activation, macrophages begin to produce reactive oxygen species and other dangerous substances. And these substances can cause severe injury to pancreatic beta cells. In addition to this, T helper activates T killers. And in activated state, T killers massively infiltrate pancreatic beta cells. On this image, we can see massive mononuclear infiltration of the pancreatic islets. And on the second image, there is also infiltration, but by the dendritic cells. Altogether, antibodies, macrophages, and T killers cause severe damage to pancreatic islets that results in death of pancreatic beta cells. And this point in pathogenesis of diabetes we call stage 1. So in stage 1, patient has autoantibodies against beta cells. Beta cells are progressively dying, but there are still enough of beta cells to maintain normal glucose level in the blood. But at some point, the total quantity of beta cells reach its functional limit, and now there is not enough of beta cells to produce sufficient amount of insulin. So because beta cells produce insulin, with death of beta cells, insulin secretion decreases. As a result, insulin level in the blood will decrease. And now there is not enough insulin to provide sufficient stimulation of insulin receptor on tissues. And with decrease in insulin stimulation, the function of GLUT transporter decreases. and if the speed of GLUT transporter decreases, the uptake of glucose by the tissues decreases. So now tissues will uptake 2 glucose molecules less. This means that these 2 glucose molecules will remain in the blood, and these 2 extra glucose molecules will cause increase in blood glucose level, a condition that we call hyperglycemia. But in addition to this, insulin deficiency will also cause decrease in amount of glucose in the tissues. So there are 2 important components in the diabetes. It's extra glucose in the blood and decrease in glucose income to the tissues. And this point in pathogenesis of diabetes type 1 we call stage 2. So in stage 2, patient will have high blood glucose level, but at this point symptoms are absent. With time, autoimmune aggression causes death of even high amount of beta cells. The lower the amount of beta cells, the lower is the insulin secretion. And with decreasing amount of insulin in the blood, the stimulation of insulin receptor decreases. This causes decrease in the rate of GLUT transportation. As a result, the uptake of glucose by the tissues decreases even further. So now GLUT transporter will deliver 2 glucose molecules less. So the amount of glucose in the tissues will decrease, but at the same time, the amount of glucose molecules in the blood will increase. So now, in the blood, patient will have 2 additional glucose molecules, and these 2 extra glucose molecules in the blood will increase blood glucose level even further. And this point in pathogenesis of diabetes type 1 we call stage 3. In stage 3, glucose level in the blood becomes significantly elevated. Why blood glucose level is so important? Because elevated blood glucose level is the major criteria of diabetes. In order to make a diagnosis diabetes, we need to determine elevated blood glucose level, simple as that. And elevation of blood glucose level we determine based on 3 major tests. First of all, it's a fasting plasma glucose level, which in case of diabetes should be higher than 126 mg or 7 millimoles. The second test is glucose tolerance test, or we call it the 2-hour plasma glucose level. And in case of diabetes, glucose level should be higher than 200 or 11.1 millimoles. And the third test is glycated hemoglobin. In case of diabetes, glycated hemoglobin should be higher than 6.5. But if person has classical symptoms of hyperglycemia and his blood glucose level is above 11.1 millimoles, it also will be enough to make a diagnosis of diabetes. So if person has classical symptoms and his blood glucose level is above 11.1, it's diabetes. But if person do not have prominent clinical symptoms, to make a diagnosis of diabetes, we need to determine abnormal blood glucose level on 2 consecutive tests. What do we mean by this? If we determine abnormal glycated hemoglobin, for example 7%, which is above 6.5, so maybe it's diabetes. In this case, we should perform a second glycated hemoglobin test, and if this test will be abnormal, 6.8% for example, which is above 6.5, 2 consecutive abnormal tests will confirm the diagnosis of diabetes. The second scenario is the case when one test is above diagnostic margins and the second one is not. In this case, we should repeat the test which is above diagnostic margins. So let's suppose that fasting plasma glucose level is above diagnostic cut point, but oral glucose tolerance test is not high enough. In this case, we do not care about glucose tolerance test. We should repeat the abnormal test, which is fasting plasma glucose. And if the second time the result is abnormal, we confirm the diagnosis of diabetes. Important that we need to know plasma glucose level not only to confirm the diagnosis, but also it's important in management of patient, because some anti-diabetic drugs have more potent glucose-lowering effect than others. To confirm the diagnosis, we need to determine abnormal glucose test 2 consecutive times. And if one test is abnormal on 2 consecutive times and the other is normal, we do not care about normal, it still will be enough to make a diagnosis of diabetes. And if person have test results near the diagnostic threshold, for example, glycated hemoglobin is 6.2, and the diabetes criteria is above 6.5. In this case, we should repeat the test in 3 to 6 months. The reason why we do care so much about blood glucose level is that continuously elevated blood glucose level can cause some serious clinical symptoms. And when clinical symptoms develop, we call this stage 3 in pathogenesis of diabetes type 1. So, what is the mechanism of clinical symptoms? First of all, diabetes causes elevated blood glucose level. With increase in blood glucose, glucose excretion increase, and we excrete glucose by the urine. Increase in glucose level in the urine we call glucoseuria. Glucose is osmotically active substance, which means that glucose will cause increase in osmotic pressure in the urine. Because water moves by osmotic gradient, this will cause increase in water excretion, and increase in diuresis we call polyuria. With increase in excretion of water, organism should increase water consumption, so patient will drink more water, and this state we call polydipsia. But the major danger of elevated blood glucose level is the ability of glucose to cause non-enzymatic glycation of proteins, including proteins on blood vessels, and eventually this will cause atherosclerosis of the blood vessels. Atherosclerosis in kidneys will cause diabetic nephropathy. In the heart, it will cause coronary artery disease. In the brain, it will increase the risk of stroke. In the nerves, it will cause diabetic neuropathy. In the retina, it will cause diabetic retinopathy. And in the peripheral blood vessels, it will cause peripheral artery disease. Exactly atherosclerosis-related injury we consider as the major complication of diabetes. But the second component of diabetes is decreasing amount of glucose in the tissues. Without sufficient income of glucose, which serves as fuel for tissues, energy production decreases. So tissues will be in energy deficient state. In response to this, tissues will activate lipolysis, which is degradation of adipose tissue. First of all, it will cause weight loss, but also with decreasing amount of fat tissue, the secretion of leptin decreases, and decrease in leptin stimulates food consumption, and increase in food consumption we call polyphagia. Lipolysis results in massive release of free fatty acids. From fatty acids we make ketone bodies, which have very similar properties to glucose. So organism tries to compensate decrease in glucose level by increasing ketone bodies production, and increase in ketone bodies will cause diabetic ketoacidosis. So to summarize, diabetes type 1 accounts only for 5 to 10% of all diabetic cases. The major pathogenic mechanism is autoimmune aggression against beta cells. The presence of autoimmune reactions we can determine based on numerous autoantibodies, and the presence of 2 or more autoantibodies tell us about stage 1 of diabetes type 1. Why autoantibodies are so important? Because the rate of progression of diabetes depends primarily on antibodies. The first detection of antibodies, their specificity, and the titer of autoantibodies. Also important that initially in diabetes, person will have high blood glucose level, and only with time clinical symptoms will develop. So in some cases, without diabetic ketoacidosis, it's quite hard to make a diagnosis. The major predisposing factor in diabetes type 1 is HLA association, and the rate of beta cells destruction is quite variable. In some cases, diabetes can progress rapidly. In some people, diabetes can have mild progression. And the first manifestation of diabetes type 1 typically is diabetic ketoacidosis due to the increase in ketone bodies production. Other symptoms include modest fasting, hyperglycemia that can rapidly change to severe hyperglycemia, and diabetic ketoacidosis. Important that symptoms will not appear while the amount of beta cells is sufficient to produce sufficient amount of insulin. But eventually, autoimmune aggression will cause insulin deficiency, and person will become dependent on insulin for survival. And insulin secretion we can determine based on concentration of C-peptide. As we know, a person with autoimmune disorder has a higher chance for the second autoimmune pathology compared to the general population. The same is true for diabetes type 1. And also, we have to remember that a small amount of patients can have idiopathic diabetes type 1, where we do not know the etiology simply because we do not see autoimmune aggression, but person has low insulin level.